Hello, I'm Petros Nihoyannopoulkos from London, UK. I work at the Hammersmith Hospital in London, and I'm Professor of Cardiology at Imperial College in London. I use contrast ultrasound for many years. I can go as far back as 20 years with one of the very early and somewhat primitive agents we had at the time, with very basic technology, because bubbles need also good sophisticated equipment in order to detect them. And that developed over the years, so much so that now contrast ultrasound is inseparable from clinical patients management for diagnostics. It has two big advantages. First, there is no ionizing radiation, and that for my patient is critical. I cannot understand how colleagues of mine use ionizing radiation diagnostic techniques when they have such a cost-effective modality to get the same result with no radiation whatsoever. Yes, someone will say MRI. Yes, I have MRI for the heart, but that's massive. It is expensive, it is huge, and there are long waiting lists for MRIs. So we have contrast ultrasound in bedside that we can reach the same, if not better results, with no side effects, extreme safety, which has been demonstrated in time and time again in multiple studies, with mortalities less than 0.5%, which is very similar to the mortality we have in everyday life. We have much more risk to die from a road traffic accident or a train accident rather than diagnostic techniques. But also the diagnostic accuracy has been unparalleled to any other imaging modality. Again, emphasized without ionizing radiation. It is a tremendous advantage. The other day I had a 50-year-old patient who came in outpatient clinic from the general practitioner, good clinical referral, chest pain, not so typical, but we needed to have an answer there and then. Had a stress ECG, which is still the first line investigation, at least in my department, and which was inconclusive. The patient could not exercise enough, the ECG was not conclusive, so we went straight on to a stress echocardiogram. The best result we had was using contrast ultrasound together with the stress. We had good functionality of the cardiac function, but also we had good perfusion information. So we had both function and perfusion in one test. One-stop shop. The patient had the answer, went home reassured with a very good life expectancy after that. So instant, one day, stop shop, no radiation, safe. What else can I have for my patient?
Do you recall any example of a patient where you thought there was a certain diagnosis, then you used contrast, and there was something you could see with the contrast that you couldn't see otherwise?
Well, contrast for imaging the cardiac apex is very important. And a lot of patients, especially with dilated hearts, big hearts, after heart attacks, they have a possible thrombus, clot in the apex of the heart, at the tip of the heart. And this is often very difficult to detect, but not only difficult to detect, but also sometimes the imaging of the apex is subject to artifacts. So we may think that there is a clot, but there isn't. Easy, one-stop shop again, inject a little bit of contrast agent, and you clarify the apex. You have a clear answer once and for all, and a clear mind.